Hello friends, this is DrRBKushwaha, professor in the division of VCC, Scotch Jammu RS4. Welcome to my YouTube channel, and if you are new to my channel, so kindly subscribe the channel and hit the bell icon for further notification. So today we have a case of intussusception in a 10 years old male stray dog. So this dog had a history of protrusion of the rectum from the anus for the last 4 days and unable to pass the feces. An animal also not taking feed and the water from the last 4 days. So animal is very dull, depressed, emaciated, and we have examined the protruded part, and we come to know that that protruded part is the rectum. This protrusion of the rectum is basically is due to the intussusception. So we have prepared this ventral abdominal area for the midline linea alba approach for the laparotomy. So you could see here, so this is the umbilicus, and we have to give the incision from just cranial to the umbilicus like this. So this animal is dehydrated, so there is a loss of the fat. Otherwise, normally in the routine case, we have to remove the fat, but here there is no need. Now you could see this fat is all, there is a dissolution of the fat because of the dehydration. Only a small amount of this subcutaneous fascia. So this is the midline here. We have to catch hold with the thumb forceps and then make the nick with the reverse blade like this, and then insert the seizure like this, and so in this way we have performed this laparotomy, midline laparotomy. So now we have to externalize this intestine. Now you could see the condition of intestine is not good. This is a cyanotic. So I have to examine the whole intestine. This is all jejunum. Otherwise, healthy intestine should be the pinkish in color. So from here onwards something is. So we have to increase the incision here. So this is the 4 days old case, so definitely now you could see. So this one is basically the colon. So I have diagnosed this case based on the history and the physical examination of the mass. So that why I didn't go for the radiography and the ultrasonography. And since we are doing this operation in emergency, means on holiday, so that this is the another reason that why we have not performed the ultrasonography and the radiography. So now you could see, so this one is the colon and the intestine has gone. So this jejunum has gone inside so this one is the part which goes inside this. So this is the intussusceptum and this is the outer covering is the intussusception. So for that we have to pull this one and simultaneously so even I think cecum, you could see this is the cecum. So cecum is also, I think it is gone inside. Yes, there was difficulty in the reduction of this intussusception mass. So we asked one assistant to push the protruded mass from the anus. So now you could see the protruded part which was visible outside, now it has gone here. So the method is by this pushing and the simultaneous slightly pulling. So in this way we can reduce the so we try to reduce the maximum length of the intestine, and let's see. Now we could see how it is coming. Now you could see this is the cecum. This means, and this one is the ileum. This is the blood vessels which is present on the antemesenteric border. Based on that we diagnose that this is the ileum. So it means the part of the jejunum and then the ileum and the cecum, it had all gone into the colon. Now you could see, so this is not a healthy, if you see, so it has started tearing, and obviously we have to resect the some portion. So now we have to decide that from where we have to remove and which portion we have to preserve. So this is the okay, colon is okay, all right. So we have to remove from here to here and then we anastomose like this, and we have to remove this part. So we have to repair this tear in the mesentery. So this is basically ileocephalic intussusception. Cut it. और सब काट दीजिए यहाँ से. हाँ, we also cut it. So now what we do, we just pour some normal saline here, and we will insert this intestine into the abdominal cavity and only expose this outside, and then we apply this intestinal clamp. This is the Doyne's intestinal clamp. So we apply one here, we resect. So we have to insert this portion, intestine. So intussusception in general we observe in the young animal, particularly after the diarrhea or incidence of this parvovirus infection. Although this is the 10 years old, but this animal also had the history of the diarrhea before occurrence of this intussusception. So what happened in the diarrhea? So there is a disturbance in the motility of the intestine. So one part of the intestine become hypermotile, whereas the other one is the normal or the become hypomotile. So what happened in general? There is a hypermotility in the anterior segment and the hypomotility in the posterior segment, and this is the reason why mostly the anterior segment protruded into the adjacent distal wall. This one is the cecum. Now you could see this is the inflamed mesenteric lymph node. So I would like to preserve this blood vessels, so I will cut from here to this one. Okay, yes, this portion. इसको लगाना था सब साइड से. अंदर लो, थोड़ा सा अंदर, हल्का सा, बस, यस, वेरी गुड. So we have the 4 intestinal clamp. Otherwise, suppose if you have only 2, so since this portion we have to remove, so even if you have the simple artery forceps, so you can apply this one, because ultimately we have to remove this portion. Otherwise, if you have, then it's always better. So this is how we applied this is the non-crushing intestinal forceps, and this is the artery forceps. Although we have this one, but this is a long, and this is we mostly use for the large animals. We don't have the smaller one. So just to avoid the unnecessary load over this area, I used this artery forceps. So now next step is we have to ligate the blood vessels. Also in this area, because of the inflammation, blood vessels is not visible very clearly, but since we have to cut from here, so this is how, this is the number 40 polygalactin 910. So I usually prefer this 40 for the dog and cat. For the cattle I use 20. So it's individual variation. Even you can use the 30 or even the 20 in this animal also. So here is the vasa recta, so sometimes there is a bleeding, so we have to ligate like this. One more ligate. So since I have not ligated here, so the moment I will cut, so there will be bleeding from this vasa recta, so it's better to ligate here. So we have next step we have to cut this one. So here it is the empty one, and here is the little bit, you can say, the fluid. So this one is the anterior segment, and there is always fluid inside the anterior, whereas this one is distal. So first we cut the distal part. So we leave like this, okay. Although I squeeze the content from the hair, otherwise you can put the hair gauze piece just to avoid the spillage of the intestinal content. So in this way we have resected the affected part. So now next step is the anastomosis. So if you see, so there is a disparity in the lumen, so I have to increase the lumen of this. Hold like this, hold. So I have to increase the lumen. So I have to slightly, you can say, hold in the slanted like this. And then I have to cut like this. Now you could see, so there is a almost, but there is a curvature, so I have to hold like this. Now leave it. So now I think now the diameter become the equal. Just hold like this. So first I have to suture this mesentery part. Since it is very small, so even so this is small one I will repair after the anastomosis of the intestine. Cut it. That's good. So it's better to cover this one portion with the drape, and then someone put the normal saline. आप यहाँ normal saline डाल दीजिए ऊपर, इसको गीला कर दीजिए. हाँ. So this is how you can make the intestine wet throughout the procedure. It should not be dried. Okay, that's good. Now that's how you just hold like this. Okay, like this. That's good. Yes, now it's okay. Yes.
Reflex.
So we always start the suturing from the mesenteric border. So this is the mesenteric border and this is the anti-mesenteric. So if you go through the textbook, so you will find that there are different method of the anastomosis of the intestine. Simple continuous to simple interrupted in single layer, but here we used to anastomose the cut part in the two layer. The first layer in the simple continuous. I have already uploaded one video of intussusception in cow also. So in that video, the way I repaired the intestine or anastomose the intestine, the similar method I am using here. So you can watch that video also. So this is how you take the bite. So this is basically suturing of the first half of the first layer. So bite is from the mucosa, then throughout the thickness, and then the serosa, and then the coming out from the mucosa of the other end. So this is a simple continuous suture pattern. So now we are approaching towards the anti-mesenteric border. So this is the very important step in the intussusception or anastomosis of this intestine. It should be done very carefully and meticulously, because the outcome of this procedure, it depends on this step. So from here onward, you take the bite like this. See carefully here. Mop it. So from here onward, now you could see the bite is still simple continuous, but the bite is taken in the reverse order. That is, the first we insert the serosa, and then the taking out from, then we come through the mucosa, and then from the mucosa, and then come out through the serosa of the other side. So this is how you can close the, now you could see this is the serosa, mucosa, and then mucosa serosa. Yes, again if you see, so I am taking bite from the serosa to mucosa and then mucosa to serosa. And while doing this step, now care should be taken that you should not puncture the take the bite the underneath side, otherwise there will be closure of the lumen. Yes. So this is how it should be taken. So now we are approaching from the place from where we have started. Not so mop it. The last bite probably. Suture become. These are the some problem if the suture becomes short, and if you want to finish with the, so at least my intention is to finish the first layer with the same thread. So this is how. So you cut this one, needle one, huh? We finished the first layer. Now we are going to apply the second layer. Release this one, no problem. You also release this one. So release this one. So we have repaired intestine into in a single layer. So even if you see, so there is a content from the this is the proximal, this is distal, so this is going very nicely, it is going, and moreover there is no leakage at all. But still I will prefer to apply the second layer. Apply one artery forceps here, small artery forceps, otherwise we will again forget and we will just okay, yeah, right. So for the second layer, so this second layer is cover the this repaired side, and as well as it will act as a serosal patching, because ultimately we are here cover the this part with the serosa of the this intestine, so like this. So here we take the bite only in the serosa and not in the mucosa or deeper structure, and we apply the traction, very mild traction like this. Our intention is just to cover the first layer. And during this second layer we should not apply traction over this one, because when you pull the this thread, so they become like this, so this area should be relaxed. So this second layer we are applying with the 3-0 suture material, because the 4-0 which we have only one piece, so that finished. So we have the 3-0, so it's not a bad idea to go with second layer with the even 3-0. Mop it. So this is the really very important step, and we should have patience while doing this. We should not do this procedure in hurry. leave it. We have so all under this the bite where so in this way we have finished this anastomosis of the intestine. So now you could see, so there is a movement when I pressing the anterior segment from here to here also, but still I will momentum here, that is the momentum do after this is the anterior which are go inside the again. So should apply the, that is called the enteroplication. So we just apply the like this. Take the bite only in the serosa. This much is sufficient, I think. Cut it. So at least this prone area I have, you could see. So this is how, even the literature said that we should also enteroplicate, but I think this area is not good. Here one is very important. So please kindly pour the namasaline. So now if you compare this time, so when we sterilize the, so at that time, so the blood was cyanotic and even the color of the intestine was also cyanotic, but now, so because of this surgery and the compression or pressure, so now the all capillary they filled up with the, you can say, blood. So there is a positive change in this color of the intestine. Even if you see, so the blood vessels which initial, you can go and you can play the video back and you can see the color when we remove, and now this is, you can see the color of. And this is done with the intention to prevent the infection, spreading of infection, whatever, if, and it will act as a physiological drainage. So in my past, so if you go through this, so these steps which all outcome of the, you have to only tie. So this is enough. So we have replaced the intestine into the abdominal cavity. Now next step is to closure of this leptotomy incision. So this is nothing special. This is just routine. So we repair in the 3 layers. So in first layer we suture this one, and the second layer with this, and finally the subcuticular. Metrogel. If you have the metrogel, then pour the metrogel. Sufficient. Enough. So ideally, after doing this step, we should change the gloves and also discard the needle holder and the seizure which we used for this anastomosis. So now we are going to repair this leptotomy incision. We start most quarterly this one. So this needle holder, the second needle holder, is not good. There's a lightening of anesthesia. Mop it. Mop it. This one is the number 1 polyglycolic acid. So here there is no intention of using this one, but it is just by chance that here the shopkeeper having the number 1 and the polyglycolic acid and the 102030 of the polygalactic 910. Otherwise you can use any one of, because both are the synthetic and the multifilament suture material. So this one is the second layer, just reinforcing the first one. So we take the bite in the underneath repaired linea alba. So now the last layer is the subcuticular. The purpose of this subcuticular layer is to obliterate the dead space, to bring the skin edges close together. When you apply the skin suture, so definitely there won't be any tension over the skin suture. So this is how you buried the knot, or this is the Aberdeen knot. And then for burying this knot, take the bag like this. So next is we go for the simple interrupted suture to repair this skin, and after that we put the prima pore. So this is all about the management of this intussusception in a 10 years old stray dog. So I hope that you have learned a lot of things. If you want to become the member of my channel, you can become the member by clicking the join button, and you can opt for the different level. If you want to contact with me, then you can choose the super gold. Otherwise you can choose any other as per the requirement. And I am also thankful to those members who have already joined my channel. So now you could see the protruded part of the rectum gone inside the. So this is the immediately happen once you reduce the intussusception. So in this way we have finished this procedure. So you could see after skin repair, so we applied this primer coat. So thank you very much for watching this video, and if you like the video, so kindly share with your friends and subscribe the channel if you have not subscribed yet.